for this session. So for today, we're going to have two lectures, I believe, as probably explained by Ma'am Ayel. By the way, my name is Francesca A. Puyat. So I'm a clinical supervisor in Operations Smile, Santa Ana. My topic is the assessment of cleft lip and palate. And then later you have another session with Miguel for COCO and aphasia intervention. Okay. We don't know if they still do it, pero maybe we can introduce ourselves a little bit kahit ng name. So maybe if I would like to ask a question or if you would like to ask a question, we're not entirely unfamiliar. So I know Carly, Mika, Hannah, and the one seated to Hannah. Ellie. Hi, Ellie. And then we have Pia. Beside, sorry? Adi. Beautiful. Ellie, Adi. Ellie, Adi. Then we have Gabby, Julia. Then, ma'am, what's your name? May. Si Shane, sorry. Sorry, Shane, yes. J- Joey. Joby. Okay. And Maui. Okay. Hello, nice to meet everyone. So, again, we're going to be talking about the assessment of cleft lip and palate. Um, I hope it's not too lengthy, although my reference for this was the module last time. So I think yun lang pala, Aya. I hope it can still serve as a parang review lecture. I feel like it's really like a classroom lecture. Okay. So basically, we will be talking about the cleft palate theme, examination of the orofacial structures, perceptual speech assessment, language screening, and some instrumental assessment procedures. All right, so for the cleft palate team, we're gonna be looking into the members of the team, yung parang basic, and then for those that have parang expanded care. Okay. So for the cleft palate team, at the minimum, these are the interventionists that should be present. So it's generally agreed upon that the cleft palate team should be composed of a surgeon, an orthodontist, a speech language pathologist, and a coordinator. Without these basic disciplines, major problems associated with clefts cannot be evaluated or treated effectively. Okay. So we have the surgeon and the orthodontist. The main role of the surgeon is to perform necessary surgeries. So I'm sure you know, we have your chyloplasty, palatoplasty. If there's a need for VPD surgery, fistula closure, they're the ones responsible for this. And yung mga other surgeries also can include revision surgeries, bone grafts, yun. And then, at times, the surgeon is the one who assumes the lead role as the head of the craniofacial team. And then we have the orthodontist. What's the difference between an orthodontist and a dentist? Would anyone like to share? Si Carla. So, sabi ko na wag mag-eye to eye. Okay. So, all orthodontists are dentists, but not all dentists are orthodontists. Yung mga orthodontists are more concerned about surgeries, ayan, yung lalo na yung mga focusing on alignment, yan, teeth, correcting bites, yan. While the dentist is more concerned about general oral health care, yan, cavities, gum disease, cleaning, etc. So anyway, in the cleft palate team, an orthodontist is the one who provides pre- and post-surgical orthodontics before and after orthodontic and bone graft surgeries. So that can include the provision of nasoalveolar molding. So that's where they have this custom-made device to gently shape the person's gum line, nose, and the lip as well. So usually these are for infants or babies, no? This is prior to the patient's first surgeries, usually yung fitting ng NAM. And then an orthodontist is also responsible for correcting malocclusions. Okay. Then of course, an essential member of the team is the SLP or the speech language pathologist. Our roles include evaluation of feeding, swallowing, speech, language, OPM resonance, and BP function of the patient. And then after the evaluation is the provision of therapy for communication and feeding or swallowing disorders. Some SLPs perform nasopharyngoscopy evaluations, but for this you would need specialized training to perform the procedure or the test safely and effectively. So our current curriculum is not sufficient in terms of conducting nasopharyngoscopy. Ayan. Additionally, we also evaluate VP function and make recommendations for surgery as needed because most likely the the effect of the VP function will be observable by speech. So sa atin, usually manggagaling yung recommendation to do further surgeries. Okay, and then as mentioned, we also have a coordinator. So the coordinator represents the team in interactions or meetings with parents, various healthcare professionals, and the community. They are responsible for planning and scheduling patients' treatment with different disciplines. Likewise, they correspond with different professionals on the team and make referrals with and outside the team. So if there are further services needed, beyond the current intervention team, they can be the one to make the coordination and referral. They also counsel the family regarding recommendations and ensure that the family will follow up on their appointments, appointments for surgery, appointments for speech therapy. A coordinator of a Cleft team may be a social worker or a clinic administrator also. So ayun, may mga iba-ibang centers or programs that have dedicated administrators and coordinators to manage operational, strategic, saka financial aspects of the care. In the absence na walang standalone coordinator, any member that we mentioned earlier can assume the role. Okay, so after the minimum professionals in the team, ayan, meron lang mga additional disciplines that can be tapped or can be referred to, yan, mga audiologists, otolaryngologists, dentists, pediatric clinicians or pediatric workers, social workers, and psychologists. So for additional services sila. And then even for the I would say expanded or more comprehensive cleft care team, they can also be referred to craniofacial surgery, radiology, and syempre when you have surgeries, anesthesiologists, cardiologists, um, if the patient also has a concomitant heart condition, yung genetics, yung geneticists to counsel families, psychiatrists, prosthetics, prosthodontics, if there's a need for additional appliances or devices, yeah. Pre and post surgeries, nursing, neurology, and ophthalmology. Again, especially if the patient has other concomitant conditions. Okay. So some key points or things that are important to remember about team care. Number one is effective communication is essential between specialists, patients, and families. Of course, we want to deliver care that is holistic and coordinated. So our work or our responsibilities are not parang standalone. Like, I will just focus on the eval and treatment as an SLP. Pero, halimbawa, may na-notice ako na deviations or need for surgery like with the orthodontist, ilalagay ko lang siya sa report ko. Tapos bahala na kung mababasa siya ng orthodontist. So hindi pwede na ganun din. The same way, some patients also have follow-up check-up with their surgeons. And then, minsan may mga fistulas na naka-open pa. Tapos, recommendation pala ng surgeon is wag nang i-close yung fistula na yon kasi mas malaki yung risk than the benefit. And then the SLP doesn't know that. So the SLP keeps recommending na magpa-fistula closure. Syempre, it will also create confusion between the family, between the team na sino ba talaga yung papakinggan or susundin namin. So we need to make sure it's coordinated. And cultural competence is also important as we have to consider language and cultural differences together with the medical and psychological needs of patients whenever we try to provide not just counseling, but treatment. Yun. We want to make sure that we've taken into context the family, ayan, their community, where they belong, their language, so that our treatment is really localized or specific sa kanila. Ayan. Teams should be organized to include specialists and allied health professionals and should include a designated patient care coordinator to facilitate patient care and team interaction. So, ayun nga, that's why important na mayroong coordinator kasi siya yung nag-oversee ng iba-ibang referrals, iba-ibang types of care of the patient. Ayan. Coordinator will ensure also that there is understanding and follow through with implementation of treatment plans, as well as appropriate referrals to mga community agency or schools if necessary. Ayan. And then, qualified team members are to maintain current practice standards. So, they can refer to other healthcare professionals as needed. But if hindi na nga within their scope yung kailangan na service ng patient, yun, you can refer them to other services like mental health, psychology, social work, audiology, genetics, etc. Another key point is regular team meetings for collaboration, again, for coordinated decision making. Mechanism for communication with families and outside professionals should also be implemented. Yun, ensuring platform, where do you communicate, when do you communicate. It's essential to provide these points to families or referring families. Yun, we need to maintain communication with professionals outside team settings. So sometimes those are teachers, also other family members. The core of the treatment and evaluation should be the patient's overall development, medical and psychological needs. So that will guide the order also of treatment. Sino yung mauuna? Ano yung unang kailangan gawin? Ano yung unang kailangan i-resolve? Yun yung keep in mind natin, patient. Comprehensive shared patient records must include all relevant medical, dental, psychological, and treatment documentation. So again, this aligns with coordinated care. Kaya kailangan everything is documented, everything is written. Ayan. So other patient records will include medical history, yan, social and psychological history, diagnosis, written treatment plans, dental findings, patient photographs, and radiographic findings. It should all be present in one location and then accessible to the members of the team. Okay, yun na yung part ko. Alright. Do you have any questions for that part? Clear naman so far? Okay, yeah. So no, it's pretty straightforward naman, the care. Yun. Maybe we just want to be more aware of our roles as well as sino yung mga pwede nating pag-referan. Kasi minsan parang we feel like, oh, I'll just refer to my, well, intern, syempre, I will refer to my CS. Pero if you're the SLP already and let's say yun, Santa Ana, or in PBM, Nordoff, yun, who do you refer to? So yun, you can refer to other members of the team. And then it's always good nga to know who are the interventionists in that center. Yeah. Okay, so now we will go to examination of the orofacial structure. So, and Ayal, I feel like this was a take two when I did a couple of weeks ago. All right. So why is it important to do a very thorough examination of orofacial structures in Cleft? Most importantly, kasi sometimes this is, halimbawa, the case is ESD, the language. So minsan yung OPM, ano na lang, they say always perceptual assessment. I will just observe while they're talking. But in Cleft care, why is this very important? You cannot not do the OPM. Anyone?
Alam niyo na yan.
Ako. Yun ang unang tanong sa boards. Oh. It's okay. It's okay to answer anything. Sino gusto si Carly sumagot? Gano'n na lang pala tayo mag-recitation. Sino ang gusto na si Pia ang sumagot? Yung mga gano'n. Carly, ikaw daw ang pinili ng class.
Parang malaman if there influence ko yung other structures ko with the possibilities.
Okay, yeah. Because simply, meron na sagot si Carly sa next question 1. So yan, because cleft lip and palate is inherently structural talaga yung condition mo. So we need to have a very thorough, very comprehensive assessment. Okay, so it's an orofacial examination. Again, sometimes it's referred to as your OPM examination or peri-oral examination. Basically, this involves assessment of structure and function. Yun. Oral structures and other facial structures that may be relevant for speech. The term is orofacial here because it encourages us to look at more than just the intraoral structure. So, even yung nasa face, kailangan din talagang evaluate. Ayan. It should always be done as part of a speech and resonance evaluation, especially if the individual has a history of cleft or craniofacial anomaly. So, you want to take note of the facial features, yun, symmetry, both at rest and in speech function. An intraoral assessment can provide valuable information that can affect the examiner's overall impressions and recommendations. Because when you do your speech sound assessment, you want to find out if there is correlation or if the status of the orofacial features or facial structures are causing the difficulties or the speech errors. Later on, we'll look more into that. Ayan. Having said the importance of an orofacial examination, assessment of VP function cannot be made based on an intraoral examination only or a visual examination only because VP closure occurs behind the velum. So usually this will take place on the plane of the hard palate, and so it is not, or it is above the level that you can view through the oral cavity. So, hindi lang siya mai-inspect talaga, yun lang, visually lang. Examiners cannot see at the point of maximum lateral pharyngeal movement from an intraoral perspective. At the oral level, lateral pharyngeal walls may actually appear to bow outward during the phonation, and VP function cannot be judged during a sustained vowel only. So, for example, sometimes we include the task, yung prolonged So that is not also sufficient to examine the VP mechanism or the VP function. Is there anyone that would like to answer why a sustained is not sufficient? Second, the baga answer. You know this, nakanayanan kayo mag-recite. Why is sustained vowel not enough to evaluate the VP function or the VP mechanism? Because it is part of the OPM assessment. It's more simple than you think. Sige. Nikki. Sige na lang this. Okay, it's okay. Sige. So of course, when you do a standalone vowel or yun, a sustained vowel, parang very konti lang. Like, they say it's like a snapshot lang of how the VP mechanism works. You will be able to evaluate the function better if there are different sounds involved, different contexts involved, kasi they would require more VP closure, basically. So yun lang, kasi mas makikita mo yung function of the VP kung mas marami silang sinasabi, kung mas complex yung sinasabi nila. The VP mechanism adjusts rapidly and precisely when we're talking. So yun, it opens, for example, open siya kapag mga nasal consonants, close kapag oral. So kapag may mas maraming co-articulation na nangyayari, mas nakikita din natin kung kumusta yun, yung function na yun. Okay, so hindi reliable to just do a sustained vowel in terms of evaluating the beeping function because you won't be able to see any errors or compensations from the patient. Okay? And despite these limitations, again, it's still important for the examiner to evaluate all of the oral structures. So this includes the status of labial competence, dental occlusion, hard palate, oral surface of the velum, uvula, tonsils, and the tongue. Okay. So di ko naman na i-explain one by one paano mag-assess nun, but more on what are the things that you should be looking out for. Okay. And yun pa rin, yun yung mga structures that you should evaluate in the OPMP of cleft lip and palate patient. Okay. So yun kasi when you also go into doing your OPM, if it's cleft lip and palate, there are structures that you anticipate will be deviated. And then there are also structures that you really want to look if they are present. So yung mga minsan deviations din siya. You wanna inspect if they're there. Okay? If they're there, if they're not there. And so for the nose in children with repaired clefts of the lip and palate, one of the things that you may observe is a flattening of one of or both of the nasal alveoli due to your lack of the normal cartilage support or deficiency naman in terms of the length of the columella since affected sa lip. In infants with bilateral clefts, dome of the nose can be directly attached to the medial segment of the lip with no columella. So, you will mark that if you observe to be passing, deviant, not passing. And then in terms of lip, yan, yung kanina yung sinabi, no, yung labial competence, you want to also look into that. In rare and extreme cases of cleft lip, a poor repaired cleft lip may still be anchored to the premaxilla with little to no nasal columella. This makes the lip deficient in length. And protrusive premaxilla makes the bilabial closure difficult. And so the production of your bilabial targets will seem atypical. But when this happens, yung deficient yung length, and it results in nasalized bilabials, meaning the lower lip makes contact with the anterior maxillary teeth. It says actually that the type of production is more visually than auditorily distracting. So it means if you don't look at a patient, you might hear or perceive a normal, sorry, you might perceive a normal sounding bilabial. But if you look at the speaker, the visual perception can be confusing. Kasi nga yun, yung upper lip, lower lip articulates with the anterior maxillary. So yeah, ganyan yung pwedeng maging itsura ng lip. Ayan. Next, you want to look into the symmetry also, not just of the lip, but the lip movement, because symmetry in lip movements are important in normal articulation. So lip retraction, pursing, rounding, uncompressing should be symmetrical. So when you ask them to blow or protrude, do a kissy face, smile, retract, it should still be symmetrical. At times, you will observe bunching on the lip rounding task. That is a sign of failure to align the fibers of the orbicularis oris during the lip repair. So you want to look into this because if there is scarring or misalignment in the lip muscles, it might not work evenly and then it will possibly or could possibly lead to bunching niya. So when there's bunching, ang nangyayari is merong side na nagre-wrinkle rather than a rounded position or a rounded presentation. Okay. So kung ganon, halimbawa merong pag-bunch on lip rounding. So nagkakaroon ng wrinkle sa isang side. Ano yung mga pwede nating isipin na mahihirapan sila na sounds? Sino?
Balance.
Vowels. Okay. Ayan. So, thank you, Hannah. So, yung mga rounded sounds, rounded vowels like O. So, yung requirement ng mga sounds kasi niyan is mag-protrude yung lips. Okay. And so again, scarring may affect lip mobility. If the scarring naman is observable sa upper lip, it can reduce lip spreading or retraction. So affected naman is teeth. Pero pwede pa rin yung rounding for U and okay. Next, orofacial structures. I-observe natin next ay tongue. Sorry, masyado ko nag-focus din sa title. So you want to check for any structural differences in the tongue bud. But it says here, be very careful about overinterpretation regarding the impact of articulation. So you see a deviation in the tongue, pero you have to be careful daw about how or in overinterpreting. Why again? Not usually you will see, oh, it's a deviation. There's no teeth. The tongue is small. The tongue is big. This will affect articulation. Why do we need to be careful? Structural, the key here also pala is structural differences. Yes.
So, for example, it might not be like significant enough to affect especially in I don't know say that
Okay, good. So basically yun, it doesn't necessarily translate in a deviation in function. So like what she said, there are articulation errors that are compensatory but are not actually caused by the tongue structure. So we don't want to focus on the structural deviation if it does not impact function because it will affect your treatment. Kasi kung structural yan, then you would say, oh, speech therapy cannot resolve this. Or I will have to refer to a surgeon or to an orthodontist for this. Okay, so since there's wide variation naman in what we consider as normal in terms of tongue anatomy, let's focus more on how the tongue moves during the speech, not just on how it looks, basically. Okay, so yun, yung mga typical presentations that you would see as deviations are macroglossia, too big, microglossia, and the ankyloglossa or ties of the lingual frenulum. It means that the lingual frenulum is too short or could be anteriorly displaced or actually it could be both then. So since we don't want to focus on the structure alone, you want to assess the function in terms of different tasks. Again, point the tongue, protrude to the midline, elevate the tip to the alveolar ridge, lateralize the labial corners of the mouth or yung side to side. Okay? Alright, then we go to dentition. Ayan, we want to see or check the following if there's absence, missing teeth. This is frequent in children with cleft palate only. Ayan, common in children with unilateral or bilateral cleft to have missing lateral incisors. When lateral incisors are present, they may erupt ectopically. So ectopically erupted teeth are teeth that have erupted in an abnormal place, such as this one. Ayan. And then rotated or malpositioned teeth are frequently seen in children with cleft lip and palate, but also seen in children with no cleft. So yun, pwede rin naman na ganun yung case yun. So again, there will be presence of ectopically erupted or extra supernumerary. So yun, ito medyo nice siya kasi pinakita ko parang paano yung progression until na mas naging normal na yung alignment. Ayan. I would say also, even in dentition, you have to be careful in interpreting the deviations that you see. For the reason that was also given na not all teeth are really critical for articulation, di ba? Ano ba yung mga teeth na mostly kailangan for your sibilants, ito your front teeth, upper incisors, di ba? Mga molars, wala naman sila masyadong impact on speech. Ayan. So you want, aside from the presence and absence, you look also into the location of the missing teeth, nasaan sila wala. Number of teeth missing, and even the presence of other structural or functional issues. Kasi mas predictive sila of the speech impact or how it will affect speech. Okay, so each case is different. Some individuals with missing teeth will have no noticeable speech issues, while others naman, okay naman yung teeth nila, complete, pero meron pa rin distortions or compensatory errors. So yun nga, you don't want to rely only on assessing the structure, the presence, the absence. Okay? All right. If a child has extensive dental caries, it says to inform parents and treatment team and or refer for team care. So it's because of, parents, they do not realize what their children's intake of soda and candy is doing to their teeth. That's why Sir Bal, sabi sa amin nun, is discouraged to give food as a reward, especially yung mga candy, biscuit, ganyan. Kasi nga, it will affect their dental care. Many parents do not brush their toddler's teeth or teach the child to brush or his or her own teeth. And then late weaning from bottle feeding can also cause dental cavities. As part of your counseling and what more holistic approach to teen care, you should also be looking into this. Okay, so for the occlusion naman, and you want to classify, they have class 1 occlusion, so that's the ideal occlusion. Class 2 or the overbite, when the lower dental arch is posterior than the upper one, or if they have class 3 occlusion or the underbite, wherein the lower molars are far too forward compared to the upper molars.
Yeah.
Okay. Ayan. Okay, example, then we also have, so yun, class 1, class 2, class 3. Then you have examples of the cross bite and the open bite. Yeah, so cross bites are actually common also for patients with cleft lip and palate. But in general, children with cleft are prone to have different types of malocclusion. Frostbite is the most common. So this is where the maxillary dental arches are inside rather than outside the mandibular arch. They can also have a complete crossbite where the entire maxillary arch is in crossbite. Malocclusions do not necessarily cause articulation problems. So as we mentioned, coexistence of two problems does not imply cause and effect. Okay? So children can have articulation problems and a malocclusion, but it doesn't mean the malocclusion is the cause. You want to look into considerations such as these two, whether the speech errors are treatable given the current structural status, or whether any physical management is required before speech therapy. Because if the error is obligatory or structural in nature, there's very little that speech therapy can change with that. So in your assessment, that's also one of the things that you want to identify or differentiate. Which is treatable, which is not. Okay. Okay ba tayo? Okay. Then we have the palate, of course, the palate and the velo. In assessing the palate, you want to look for presence of fistulas, even in repaired cleft lip and palate. So you want to note their location and size. Yeah, this is also a why question that I will ask. Why is the location and the size of the fistula important? Gusto natin yung isa Anyone? Yes.
Case natin ng clue kung anong possible maging error share ng kid.
Okay, all right. So it will actually help us, yes, understand the errors and if it actually has any effect in speech at all. So location can affect which speech sounds are impacted. Halimbawa, nandun sila sa near the alveolar ridge, yan. Or is it mid-palate? Is it posterior? You'll be able to have an idea where the air escapes. And then the size, because it determines how much air leaks through. Of course, if mas malaki yung fistula, mas magkakaroon ng more noticeable issues like hypernasality or nasal air emission. A general rule of thumb, although hindi naman to parang like general rule of thumb naman eh. Pero yun, fistula larger than 3 to 5 millimeters. I remember before it was the 5 millimeters, especially when located in the hard palate or willow, is more likely to cause perceptible hypernasality. But meron din naman akong nabasa na as smaller fistula as little as 1 to 2 millimeters can affect speech depending on the location. So if it's in the anterior palates, it can affect because it will have an impact in terms of producing high pressure sounds. SPT yan. And it will also be more observable in a person who cannot adequately compensate. So that's why the size and the location are important. You also want to find out if the fistula is patent or if it is open all the way through the nasal cavity. A dentist or a plastic surgeon can be the one to help determine patency or how open it is by temporarily covering the fistula with adhesive material that sticks to the mucosal surface of the palate. And then they can check if the nasal air loss is eliminated because you've made an obstruction. So, some fistulas kasi are blind-ended. Ayan. So, post-surgical fistulas can occur anywhere in the repaired hard or soft palate, but in contrast to the patent fistulas, there are also blind-ended fistulas. So it means there's a fistula that, of course, there's a hole. You will see there's a hole during the oral exam, but it doesn't really go all the way through the nasal side. So para lang siyang shallow pouch or pit with a dead end. So wala namang mag-escape na air or sound through it and it will not affect speech. So that's why you want to also determine if the fistula is patent or blind-ended. And it will not be a route for loss of oral airstream. Some may be along the lines of premaxillary sutures. This will maybe an extension of an unoperated alveolar cleft. If the fistula is problematic for speech, discuss first with the parents, then the treatment team. Because they will, pagka yan, nag-advise tayo na meron pong fistula, problematic ka po siya for speech, it will is causing the hypernasality. You want to consult and counsel first because they will undergo surgery na naman. So yung family should also be informed of the possible risks, benefits. Usually the surgeon also is involved in this discussion. Kaya minsan, may mga cases talaga na they opt not to close it anymore, especially pag mas matanda na. Diba? So, ayun, more on compensatory na nga lang yung mangyayari. Hindi rin natin pwedeng ipilit. Okay, so ayan. Ito example of a fistula. What about the second picture? What do you think is that showing? Yes, correct. Okay, submucous cleft. All right. So another thing that you want to look in terms of structure and deviation is if there is a presence of a submucous cleft palate. A quick intraoral view may miss a submucous cleft. Unlike an overt cleft, the surface kasi of the mouth looks normal. So it makes it difficult to spot even when you do an OPM exam. So there are three classic signs of a submucous cleft: a bifid uvula or a split uvula, a bony notch in the back of the hard palate, and a translucent or bluish zone or the zona pellucida in the soft palate. So that's why letter B is important, you have to palpate the palatal vault with your finger. Okay? Some submucous cleft are obvious to the eye. So if it's obvious, you saw naman the bifid uvula, you saw the bluish zone, whitish bluish zone. Palpation may not be necessary, but it's still good to do the palpation of the palate if you see that the speech has inadequate is showing or suggesting inadequate pupil closure. You want to identify the presence of that bony notch. Okay. Lack of visible signs doesn't, yung buong slide na to is just saying na lack of visible signs doesn't rule out submucous cleft as cause of hypernasal speech. Ayan. Previous examiners may assume lack of visible signs of the cleft, meaning hypernasal speech has no physical cause and should therefore be referred to speech therapy kasi it's not structural in nature. Wala namang signs na may submucous cleft. And then, we have to do our part in making sure that this assumption is sound because it can be wrong. So it's important to consider that the following, the presence or the absence of the three classic signs, but then one or more of three classic signs of a submucous cleft may be present in an individual without VPI in speech, meaning pwedeng typical brain speech, but they have a submucous cleft. Pwede rin naman na severe yung VPI nila, but wala yung classic signs of a submucous cleft. So then you can make a better differential diagnosis of what really is causing the VPI. So hindi naman lang dahil sa submucous. Okay. Ayun. In terms of evaluating your palate and bilum, or the palate and bilum, some defects vary in posterior to anterior extent and in width. Ayan, sometimes, or actually, usually pala, sorry, defects of the hard and soft palate usually occur together. But there are instances that the soft palate alone can have a muscular deficiency. So it's more soft than it usually is. The weak area kasi has less of that muscle bulk, yun nga, muscle deficiency. So when you make the person say yung test, the soft palate may form a V or a tent-shaped appearance instead of lifting fully and symmetrically. So this shape suggests nga that there is reduced muscle tone and can also impact speech and swallowing. So the test can be done here. If there is evidence of an asymptomatic submucous defect, yung hindi naman siya nagko-cause ng any changes in speech or swallowing, advise the parents to discuss with a physician for the reason that the findings have a genetic significance, maybe in their family. Okay. For post-surgical cases, you also want to look at the palate in terms of dehiscence. So, nag-break or nag-open yung repaired cleft palate, it will lead to a hole, so that will be called a palatal fistula. It's a post-surgical complication that may have different causes. So either nagkaroon masyado ng tension doon sa wound or sa stitch, can have be because of hematoma, infection, ayan, poor wound healing or trauma from inadequate post-operative care. This opening kasi, if there is a palatal fistula, it can cause problems with feeding, speech, and nasal emission. Therefore, you are again required to refer for medical attention or surgical care. Okay. So while here, we were asked to do an to see the function of the soft palate. It's again reminding us that it is not sufficient to determine VP closure or VP dysfunction. Okay. It does inform us about the movement capability of the soft palate during phonation and whether that movement is symmetrical, but not for VP function. Okay. Function. Okay. VP closure cannot be observed on intraoral view. VP closure occurs in the level of the nasopharynx, so it's not in line of your intraoral view. Even if the palate is short, it cannot be again observed from intraoral view. Therefore, we need imaging studies to make an accurate assessment of function, functional velar length, depth, width, of the nasopharynx as well as physiology of VP closure per speech. Ayan. And then we're going to the last few na lang structures of the OPMD. So we have the pharynx. You want to look at the structure of the anterior facial pillars. So yan, it has the palatobrosus muscle and posterior pillars of the palatopharyngeus muscle. Palatine tonsils, where it is situated in the oropharynx between the anterior and posterior pillars. Now, please refer to the picture also. Ayan. Normally, a palatine tonsil is low in the pharynx to influence, it's normally low, in pharynx to influence VP closure in speech. But upper poles of enlarged tonsils may extend high enough that such that it will be in between the velum and posterior pharyngeal wall. So if this happens, it will have or it will interfere with the VP closure. If this happen or if this is happening, video nasopharyngoscopy or video fluoroscopy is required to examine if the tonsils have a role in VP closure. Okay. Yeah. When you ask your patient to phonique, you may see medial movement of one or both set of the pillars or movement of the lateral pharyngeal musculature behind the posterior pillars. Such movement may or may not contribute to the VP closure. Again, you will need dynamic imaging studies or instrumental assessment to view and understand the physiology of the VP closure. There are reported cases of webbing of posterior facial pillars. So, it's said that it will inhibit velar movement. However, there is no way of knowing how often it occurs. So again, we cannot know how often it influences VP closure. Okay, ang dami nitong wall of text na ito. Basically, saying that they need imaging. Basically yan. But yun, there is, in literature, it's said kasi na the contribution of both the lateral pharyngeal wall movement towards the midline and posterior pharyngeal wall movement anteriorly, it contributes to the VP closure in speech. But again, we cannot view that in an intraoral exam. So the observations will be limited. It is important to record any observations and forward them to professionals so that we may refer them to instrumental testing. Accurate assessment on how much the pharyngeal walls contribute to VP closure requires instrumental tests again. Okay. This one naman is for tonsils and adenoids. So we have the tonsil and the adenoid pad. These are lymphoid tissue and part of Wallier string. However, they have disparate origins and growth cycles. So in a growing child, the tonsils may be large and adenoids small or vice versa. That's what's expected. Since the adenoid pad is in the posterior nasopharynx, it is more likely that the tonsils are the one influencing VP closure. Thank you. Okay. As an on-site SLP, it is important to recognize what has happened in the child's growth cycle or medical history so that we can make appropriate referrals and know that speech therapy cannot change an excessively deep pharynx or functionally short velum. Because again, these are inherently structural in nature. The imaging studies will confirm if the issue is due to these structures or deviations in structures. Okay. All right. Let's take a break. You want to take a break? I want to take a break. Let's take a 5-minute break, and then we're gonna go to perceptual speech assessment. To the next portion of your assessment, which is your perceptual speech assessment. Okay. It says that the most important tool that we have to assess speech resonance and voice is your examiner's ear. So the clinical ear. That's the most important tool. As part of the perceptual evaluation, the examiner should determine whether speech errors or speech sound production is affected by the structure, yun nga, let's say, BP insufficiency, yung kanina malocclusion, deviation sa tongue, sa lip, or is it because of an abnormal function? Right. It is important to determine the cause, so since it guides us in the treatment plan that we will prepare. If there is no this is interesting. If there is no abnormality as judged by a perceptual evaluation, then it does not matter what the instrumental procedures show. So meaning, if the person's speech if the person's speech sounds normal to listeners during a perceptual evaluation, it doesn't matter what the detailed instrumental tests or imaging studies show. Treatment will only start if the listener detects a clear speech problem. So, kasi nga naman, why would we yeah, to do the treatment if okay naman pala. It is only when the perceptual evaluation shows an abnormality that treatment is ever initiated. So, yeah. The way speech sounds is heard or how it is perceived by the human ear is the most important factor in deciding when or whether someone needs treatment. Okay, so not just what the tests reveal. Okay, so the protocol for assessing cleft palate speech is summarized in 4 steps. Obtain an adequate speech sample, analyze the speech sample, correlate perceptual speech data with your orofacial exam findings, and then interpret the clinical data and make recommendations. So it's so simple, diba? Sandaan na interns. That's simple. 4 steps lang daw. So yeah, we will go through each step. Okay. So the first one is to obtain an adequate speech sample. This sample will yield the necessary data for reliable and accurate analysis and speech diagnosis, and will also inform us regarding treatment planning. For team-based SLP, so yun, yung working in a cleft care center talaga, it's desirable and actually very ideal to obtain a sample that yields data for quality improvement and clinical audit evaluations and for reporting of speech outcomes. So a good sample kasi will help track how well treatments work over time. So that is what clinical audit means. It also dictates the support quality improvements efforts across the team. Support a quality improvement efforts across the team. So example, nagdagdag ng ganitong material, nag-improve kasi periodically nag-imaging study or periodically nagkakaroon ng comprehensive speech and language screening. Ayan. And then having that data also allows the team to report consistent speech outcomes, which is valuable for research, funding, tsaka sharing of best practices. So when we have an adequate speech sample approach, it saves time and makes the evaluation process more efficient and effective, not just for SSLPs, but for the entire team. Okay. It's recommended to have a structured speech sample to facilitate and identify specific cleft palate error types and error patterns. Speech is a complex behavioral task and speakers can show variation that the SLPs may identify as errors or deviations across different speech contexts and tasks. So, you have to identify, yun nga, again, if the errors are acceptable, let's say, in this linguistic community or in these contexts. It says the more generic or uncontrolled, so if it's generic, it's uncontrolled. If it's specific, it is controlled. The more generic or uncontrolled the speech sample, the more likely that the identification of speech errors will be inaccurate or incomplete, making treatment decisions inaccurate as well. So if it's too general kasi, or not planned according to the individual's errors, it's harder to spot. It's harder to find out all the speech errors that they can have. So using a well-structured controlled speech sample helps a more accurate diagnosis and of course, better treatment plan. Okay, so some things that we use in terms of articulation tests is formal articulation tests, but we also incorporate other tests. Yun, a single sound syllable repetition, sentence repetition, counting, connected speech, stimulability testing. Okay. So formal articulation tests such as yung mga GFTA or Goldman-Fristow test of articulation, Kahn-Lewis phonological analysis, Manson-Brinfeld test of phonology, or clinical assessment of articulation and phonology. These can be used for the assessment of speech production. These are tests that usually provide normative data for determining the child's development, articulation, and phonology status. This is actually recommended for younger patients. Any insights why for younger children this is recommended? Ayan. So, well, it helps with, of course, early identification. So, if you catch the speech difficulties or speech problems early, if you can do early intervention or a more timely intervention, basically. Then, in terms of tracking progress, the norm reference test can also provide the baseline or a much clearer baseline and can help in terms of monitoring the speech of the child, the speech development over time. Okay. Having said that, while formal articulation tests are popular, since they are usually single word tests, there are also disadvantages. You have to think of it in the context in talaga of a patient with cleft lip and palate. Why it's not the most ideal procedure. So yun, some children are able to produce a sound at the single word level, but not in the connected speech. There will be an increase in utterance length and phonemic complexity, making the errors more apparent. Single words are not a good representation of the child's actual speech abilities for that reason. Single word tests are also designed to assess each phoneme in one word position rather than many words in connected speech. Additionally, the test phoneme may be affected by the phonemic context of the word. So, for example, the single word test includes the word window. So it's not appropriate because of the combination of N and D. So there's a medial D and then an N, which is a continuous sound, pero same placement. Can cause confusion. Test and test forms are expensive, which increases the ultimate cost of care. So yun, it can also be time consuming to administer. Ayan, yung cost is a particular issue for those that have challenges in financing their teams. Yeah. It can affect also since it's expensive, you have to return investment pa, ganyan. So yeah, factors like that. So what we can do is administer other types of tests, tests that will involve repetition, so particularly repetition of sentences. These have been proven to provide better diagnostic information and are actually more valid in representing normal speech production. Additionally, like in the last few key points, it takes less time to complete and there is nothing to purchase. So yeah. Okay, so we start with a single sound. You will see that later on, yung single sound and syllable repetition have some similarities. Yan, so may mga overlap siya. This is used if the child has limited connected speech or the examiner wants to isolate specific phonemes. Basically, you will ask the child to repeat single sounds or single syllables. For vowels, voice continuants, for example, V and Z, and voiceless consonants can be produced in isolation. Primarily because they are already continuant sounds. So they can be made alone. They will involve continuous airflow. And even if you do not pair it with a vowel, you'll be able to clearly hear it. So it will not rely on that vowel. Conversely, voiced plosives and voiced affricates like ba, bi, yeah, daddy, gabi, ja, ji can be produced only with a vowel. So the reason for this is actually yung opposite lang din naman. These sounds require vocal fold vibration and build up and release of air. So it's more easily perceivable when it's followed by a vowel. Without the vowel, it can be harder to perceive as the voicing and release cues are less distinct. Okay, then, by having the child attempt to imitate all speech sounds in isolation or in syllable, the examiner can be able to determine the child's ability to achieve appropriate speech sound placement at this basic level. So ito kasi yung pinakamadaling level. Imitation of isolated phonemes can also be used to test resonance and determine nasal emission. So even from the single sound level. To test for hypernasality, prolongation of the sound should be a vowel because vowels are purely resonant sounds. So like an A, an E. Additionally, when you use a vowel to test for hypernasality, you want to do both high vowels and low vowels to help determine if there is consistency in hypernasality or whether it is just vowel specific or occurs only on the high vowel. And then for nasal emission naman, you want to use a pressure, sorry, nag-cork ako lang. To use a pressure sensitive consonant. So the best consonant for this purpose is a prolonged S because it is voiceless, it is continuant, and it will require sustained airflow. If you want to test naman for hyponasality or cul-de-sac resonance, use the prolongation of an N sound because that is an inherently nasal sound. With the lips totally closed, the sound is supposed to travel through the pharynx and nasal cavity. If there is obstruction, yun nga, kasi we suspect it's hyponasal, there is obstruction, prolongation of the sound will be noticeably difficult. There will be distortion, it will not sound as nasal. Okay. Then you have the syllable repetition. Informal tests using the syllable repetition can be done instead of a formal test of articulation. So again, it's faster, it's cheaper, it provides more diagnostic information. Here you will ask the child to produce syllables repetitively to assess each sound individually. So pa, 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 pe, 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 pe. The initial position of the sound is always tested with these syllables. So much more important to assess it at the syllable initial. But when you are making a child repeat the syllables, there is also assessment of the sound in the medial position. Say, pa, 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 pa. So nagpe-place mo rin yung pa sound in the middle. Hindi always necessary, but the final position can also be tested through having the child repeat syllables in the syllable final. So yeah, the vowel will precede the consonant up, 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 up. So the advantages of doing a syllable repetition task is allows the examiner to assess one consonant and one vowel at a time, eliminates the effect of other continuous consonant sounds. So it's easier for us to identify specific speech sound errors. Certain syllables can be selected to test for nasal emission on consonants or hypernasality on vowels. And then the rapid repetition of syllables may also uncover evidence of oral motor dysfunction. It's similar to when you do your DK rates. Okay. So how do we test for nasal emission when we are doing syllable repetition? So you want to ask the child to repeat the syllable with a high pressure consonants. Usually these are your plosives, fricatives, and affricates, where the consonant is voiceless. So yun, pa, p, and t, and you can use those as well. A voiceless phoneme is used rather than the voice cognate or the voice counterpart because nasal emission is easier to hear when there is no phonation. And then voiceless consonants then have a higher amount of airflow than their voice cognates. The vocal folds will attenuate the flow. Therefore, audible nasal emission is more likely to occur on these sounds. Mas ma-observe din sila. When you choose your high pressure consonant that is voiceless, you pair it with, again, a low vowel and a high vowel. Okay? So with an A, with an E. This will allow the examiner to assess articulation placement and the presence of nasal emission in each consonant. And then similar as kanina, it will help us see if it's if it's consistent or if it's just specific to certain vowels. Okay. When you do your when you do your sentence repetition, yeah, to test speech and resonance in connected speech and to also obtain some clues regarding expressive language, the examiner should have a battery of sentences for the child to repeat. Please remember that each sentence should contain phonemes that are similar in articulatory placement. Okay, ready to count? Yeah. To test for nasal emission, you want to have a sample that contains, again, many pressure-sensitive consonants. Again, particularly those that are voiceless. I see the sun in the sky. Okay, and then for hypernasality, the sample should contain an oral sound. Yeah, so for this one, we use be, by, baby, a bib. To make it easier for hypernasality, you want to separate out the effect of nasal air emission or compensatory error by using a sample of sentences with a large number of low pressure consonants. How are you? Okay. Then to test for hyponasality, use sentences with higher frequency of nasal phonemes. My mama made lemonade for me. Again, because if there is obstruction, it will be more difficult. Yeah. Examiner can quickly and easily test for artic errors, abnormal resonance, and nasal emission in a connected speech environment. Can also determine whether there is consistent or inconsistent nasal emission in connected speech. So even if you tested already hypernasality in the syllable or the isolated, you still want to do it again in the sentence level. Now, counting is for younger patients or maybe just children who do not participate in conversation. Diba? So, I'm sure the interns have experienced this. Like, nagtutalk naman yung bata pero hindi talaga in the sentence level or hindi naging conversational. So, ang hirap to get a connected speech sample. So, these are things that we can do yan. Serial counting, 1 to 10, 1 to 20, counting from 60 to 70 or simply repeating 60, 60, 60 can also be very informative because one, they contain a combination of a high vowel, yung P, the sibilant S, so again, di ba for nasal emission, that's good to use, and even a triple blend, yung KS6. You can also ask them to recite Days of the Week. So it's familiar naman if they can. Recite the alphabet. So I guess this one yung isa sa mga pinaka madali na ipa-facilitate. And then reciting memorized materials. That's why we excel interns. You can do nursery rhymes, familiar songs like Happy Birthday, just so you can have a connected speech sample. Ayan. Although a single word test helps the examiner isolate the production of individual phonemes, it is important to assess articulation and resonance in the connected speech level. So for the reason that the connected speech increases demands on our VP mechanism to achieve and maintain closure, so hypernasality and nasal emission are more apparent in connected speech than in single words. So for those that have had sessions or evaluation sessions with clients with cleft lip and band, you may observe that some of them parang okay naman in the single word level. Like, nag-gets ko naman yung sinabi niya. Usually, intelligible naman. But of course, it's just the word level kasi. And then yun na, pag nag-start na nagkwento yung bata, yun na, nahirapan na to understand or yun, the speech becomes less intelligible. As a result, hypernasality and nasal emission are more apparent in connected speech than in single words. There is also an increase in articulation errors during this type of context because of the production of continuous utterances. So the co-articulations are more frequent, more apparent. Connected speech can be spontaneous, or the examiner can ask the child to repeat syllables or sentences over and over to simulate connected speech. Again, if hindi talaga kaya kumuha ng longer sample or not that conversational. Okay, and then we have the last test, which is stimulability testing. So this is a very crucial part of the articulation assessment. Stimulability testing with isolated sounds or yung mga syllables, hindi syllables, informs us of the speaker's motor phonetic ability. Likewise, data from this testing guides us in determining start points. So in terms of goal setting, you want to start with sounds that they are stimulable too. Kasi you can see that if you apply certain, let's say, ABPK cues, tas nako-correct naman niya pala yung kanyang speech, then you want to start with those sounds already. Okay. So, for example, ayan, as applied to cleft palate speech, substitution of a glottal stop for an oral stop like a ba or a pa may or may not represent an inventory constraint if stimulability testing demonstrates that the speaker can produce the target for which the glottal stop is substituted. So, ayun nga, for example, a person uses a glottal stop because that's yung weakest stop at the level of your gluteus and ganon. Instead of a normal oral sound like a pa or a ta. This substitution might not mean that they can't say the correct sound at all. It tells us through the stimulability testing that they can make the right sound provided the correct level or type of assistance. Okay. So this will lead you to think it's a compensatory error, learned misarticulation. Okay, so yun lang, habit lang or difficult. Okay. After you obtain your speech sample, of course, you have to analyze the speech sample. Part of that is in evaluating the speech intelligibility. So you have ratings, often including mild, moderate, or severe ratings. For standard tests or scales for intelligibility, please ensure that the scale that you use is specific or specified in your report so that other future SLPs may make adequate comparison to your results to judge progress. So, same intelligibility rating yung ginagamit. Para nga makita natin if there have been changes. Otherwise, you may use a 4-point scale such as within normal limits, speech is always easy to understand, mild, speech is occasionally hard to understand, moderate, speech is often hard to understand, or severe, speech is hard to understand most or all of the time. When using any scale, please remember to include clear descriptors for the measurement so that they all know what this means, especially other members of the team, family members of the patient. For resonance and hypernasality, patient's resonance may indicate presence or absence of a VP dysfunction, but it is not definitive. So it means kasi that halimbawa you perceive hypernasal speech. It doesn't always mean kasi it's because of a VP dysfunction. Yeah. It is important that you note your findings and correlate with other findings such as your voice test, articulation test, and instrumental assessment. With hypernasality, this is an acoustic phenomenon. So this excess sound where there shouldn't be, which is occurs within the abnormal opening in between the nasal and oral passage during speech. So causes may be structural, like VP insufficiency, functional, like VP incompetence, or behavioral, such as VP mislearning. Or pwede rin naman na combined sila. You will know that it is VP mislearning if through the correction of select speech sound errors, the hypernasality is nare-resolve siya. So then you know it's just mislearning. Okay. Hyponasality naman occurs when there is not enough acoustic energy resonating in the nasal cavity. So di ba parang stuffy, yung parang resonance na lumalabas parang may sipon. So during speech, due to blockage in nasal cavity, again, causes can be temporary, like yun nga, sinus congestion, colds, allergies, or it can be a permanent structural problem, narrow airway, enlarged tonsils, or adenoids. A cul-de-sac resonance occurs when the sound resonates in a cavity, oral, nasal, or pharyngeal, but is trapped and cannot exit due to an obstruction. So yung potato in the mouth na resonance. Voice would usually be perceived as muffled or low intensity. Then a mixed resonance indicates presence of hypernasality, hypo, and or cul-de-sac resonance in the same speech signal. can be caused by velopharyngeal mislearning, obstructions in the nasopharynx, or abrasion. Then you have your nasal air emission. So sometimes I feel like this is the more kung saan ako confused kung is it nasal air emission or is it hypernasality because there is excess nasal sound. But nasal air emission, yung kung kanina hypernasality is an acoustic, this one is aerodynamic, is excess air released or that escapes through your nasal cavity. It can be audible or inaudible in various degrees. So audible nasal air emission should not be confused with hypernasality. When you hear a nasal air emission, you will really hear parang excess air, like, so it sounds nasal, pero may bugarin talaga ng air. Yeah. So for beginning clinicians or beginning with the cleft palate practice, syempre yun na, minsan ang hirap to determine what did I hear. You can do further testing. So yun, pwedeng visual detection or tactile detection through the use of nasal mirrors, dental mirror, place it under the nostril, air paddle, listening tubes, among other techniques. Kasi yun, for example, you use a listening tube. The tube, like an oronasal listener, para siyang stethoscope. So you place it in your ear. There's a tube, you place it under the nostril. And then if there's nasal air emission, maririnig mo talaga siya. Mas magnified yung sound. And then for visual detection naman yun, yung mga dental mirror or air paddle, if you place it under the nostril, there's nasal air emission, it will move. Okay? You just have to be careful in explaining, lalo na with the air paddle, kasi sometimes it moves, tas galing pala sa ilalim. Yung air. So yeah. A patient with nasal air emission would often exhibit speech with weak oral consonants and compensatory articulation errors. Another sign that they may have nasal air emission is the presence of a nasal grimace. So yun, parang nagsisnort. Ayan, there's a nasal grimace present, muscle contractions just above the nasal bridge and or at the side of it. So yun yung pwede, if you see your patient doing that, they might have nasal air emission. Or if they have nasal air emission, you want to check if there's presence or absence of a nasal grimace. Confirm din siya. And then some patients that are diagnosed with cleft lip and palate have voice disorders. So in an attempt to be understood, patients would sometimes place extra strain on their larynx and cause dysphonia. Some of them have very, very soft voice. So yun, minsan mahina yung voice in an attempt to mask the errors. So yun, that's another presentation. Okay. Errors in speech production. So cleft patients may exhibit various consonant production errors. It is important to classify and distinguish if the errors are due to clefts. And under cleft errors, you have the obligatory or compensatory errors. If they are developmental in nature, or mga phonological processes, caused by factors other than clefts. So I think that's one of the primary distinctions that you also have to make when you're doing an assessment. Firstly, you want to identify if they are phonological or articulation in nature. Then, once you've identified their non-phonological processes, you want to look into whether they are obligatory or compensatory. Okay, so why do we also have to differentiate between the two? Obligatory errors are structural in nature and is directly due to their anatomy. So you can see this if the articulation placement is normal, tama naman yung placement, but because the structure is abnormal or has deviation, the speech production is erroneous. So such errors need surgical or prosthetic intervention to be corrected. Again, very little help that speech therapy can do. Very little change yung mangyayari if it's structural in nature. And then you have the compensatory errors, which are learned productions that may persist even after corrective procedures. So yun yung isa rin, minsan, minsan, dahil nangyari, okay naman na nagpa-chyloplasty, palatoplasty, wala ng fistula, but mababa pa yung intelligibility. So, ayun. That's when speech therapy really has to occur. Due to the patient trying to compensate, this happens because the patient is trying to compensate for their previous structural inadequacies. So this can be, when compensatories are due to VPI, the manner of production is usually maintained. So, example, a plosive is substituted with another plosive. A fricative is usually substituted with another fricative. But the placement of production, sometimes it can be moved posteriorly to the pharynx where there is airflow. So, for example, yun, yung mga, pwede rin yung mga glottal stop, yun, they will force the sound there, becomes In other cases naman, the placement is similar. Naman, like, they want to say ball, but it becomes small, so it means the manner has changed to a voice nasal sound. Okay, so these are the common compensatory errors that we see for cleft type speech. Again, you have the glottal stop. It's the production of a sound using vocal fold adduction. Yeah, for glottal stop, you can also see some. Well, you can watch out or look out for tension, ganyan in the air in the throat area. Pharyngeal fricatives, it means that a fricative sound is produced but in the throat and the back of the tongue with the back of the tongue instead of in the mouth with the front of the tongue. A nasal fricative is snorted air through the nose while producing a fricative. Yan. So, yung parang ginagawa namin na pangtanda dito is what sound are they trying to produce? Yan, basically, are they trying to produce a stop? Are they trying to produce a fricative? And then, where does it actually happen? Is it in the level of the gluteus? Is it in the nasal area? Pharyngeal area? A mid-dorsum palatal stop is when airflow is occluded by the dorsum of the tongue to produce a stop consonant. A pharyngeal plosive is when you move the tongue posteriorly to meet the pharyngeal wall of the area of the pharynx. Moves inward towards to meet the tongue, and then air is quickly flowing through the limited airway to produce this. So, kaya yung speech sample din natin needs to be specific, needs to be controlled, yun na, so that you can anticipate what sounds they are trying to make, and then where are they actually making them. Other oral misarticulations may be noted due to dental issues, missing teeth, crowding, or due to malocclusions. Okay. After you've analyzed, you want to correlate perceptual speech data with your orofacial exam findings. Speech data can be examined to determine if there are any relationships or correlations between the oral structural or physical findings during your OPME and speech articulation errors. So for example, is the nasal air emission heard in a given patient's speech the result of an oronasal fistula? Therefore, that will make the nasal air emission an obligatory or a passive error rather than learned. If this is the case, the solution is closure of fistula, not speech therapy. Nasal air emission secondary to persisting physical insufficiency of the VP system. So for example, VP insufficiency, again, best approach surgically or with an appliance. But if the nasal emission persists even in the absence of a fistula, wala namang fistula, or physically based, wala namang yun. It's not because of a physically based VPI or VPP. It will point to a learned pattern. It will point to a compensatory error and therefore makes it an appropriate target for speech therapy, not physical damage. These correlations, including dental and occlusal deviations, are key components in differential diagnosis and affect treatment recommendations. You may also determine relationships between speech errors and oral structural deviations. Okay. So yun yung medyo, I guess, tricky when you're doing assessment. Kasi nga, hindi ka laging sure. Hindi ka laging sure kung structural ba siya, especially if yung ang suspected mo is BP dysfunction na. Then you have to recommend or refer to imaging. Sometimes naman, there's recommendation to do therapy muna for a certain period. And if you feel like hindi talaga nagkakaroon ng change, then you can refer to instrumental testing. Okay, so the last step of the protocol is to interpret the clinical data and make recommendations. So more often than not, experienced clinicians are able to diagnose or rule out a true cleft-related or non-cleft BP insufficiency based on clinical findings alone and present a definitive speech diagnosis. So in some cases, however, clinical evaluation does not yield a definitive diagnosis. Hindi pa rin talaga ma-rule out na it's non-structural. SLP may develop a diagnostic hunch or a more tentative diagnosis that usually warrants instrumental testing. So this is typically an imaging study so that we can rule out or confirm a true physically based BP dysfunction. For some children, a period of diagnostic therapy may be warranted before successful or informative imaging study can be obtained. So why do we need a period of diagnostic therapy? Pwede kasing, pwede may isipan, ay, delay lalo, di ba? Kasi papatagalin mo pa. So, one reason is some children may not be cooperative. So they may not cooperate well or produce the correct speech sound during the study. So yung results will still be clear or unhelpful. But if they're doing therapy muna for that period, they can still learn how to use their speech mechanism better, use better awareness of sounds also. Production of speech sounds can be more consistent. And then this can lead, of course, to more accurate and meaningful imaging results. Mas maging reliable, basically, result of the instrumental testing. Okay. Yan, malapit na tayo, guys. Okay, so we do a language screening also. Although, if it's really like, if it's purely cleft lip and palate diagnosis, may mga, kaya nga may mga times, language screening na lang talaga yung ginagawa as opposed to like a really comprehensive language evaluation. Because ang anticipated is, it's just really speech that's gonna be mostly affected. Although speech and language are interrelated, with cleft lip and palate kasi yun, parang wala namang cognition problems, yun, wala namang masyadong language problems dapat na mangyari. So yeah. It is important that language development is closely monitored throughout preschool years since children with cleft palate or craniofacial syndromes are still at risk for language delay, mostly rin yung expressive language delay. This can be done yung monitoring through screenings at the time of yearly visits, yung mga scheduled follow-ups to the cleft palate or craniofacial team. If language problems are suspected from the screening or the parents express concerns, so ito rin yung lagi namin remind sa mga practicing clinicians for cleft palate care, you have to ask also the parent if it's a concern for them. If naman, oo, yun, a comprehensive language evaluation is warranted. So you might want to ask questions like, how do they usually communicate? How are they in school? How do they usually understand instructions? Are they able to communicate with their peers? Yeah. A comprehensive language evaluation should routinely be done for children who have additional risk factors for language disorders. So, ayan, kung meron silang hearing loss, some have cleft lip and palate, and then meron din GDP, ganyan, other syndromes that might have cognitive impact. So, yan, sila yung kailangan mag-undergo ng mga language evaluation. If a language disorder is identified, intervention should be initiated as soon as possible to ensure the best outcome. So you don't want to also confuse, let's say, minimal lang siyang mag-express during the evaluation already as a, oh, that's a sign or of a language delay or of a language disorder. Could be other factors lang then. Okay. So yan, paulit-ulit pinabanggit yung instrumental assessment. Okay, and this is going to discuss three, yeah. But first, before we do the discussion on video fluoroscopy, nasopharyngoscopy, and isometry, and we want to go into VP dysfunction a bit. And so VP dysfunction is an umbrella term. It refers to any situation in which an individual is unable to completely close the nasal airway during speech. So you want to look at it in three factors again. If it is anatomical, it's insufficiency. If it's incompetence, it's functional. And if it's mislearning, it's behavioral. So I saw this picture, yeah. But VP insufficiency, the door is too small for the doorway. Air will escape through the nose. Incompetence, the door doesn't get the right signals to open. It's not working that well. Neurogenic cases, so that's why it often leads to the incompetence of the VP mechanism. And then mislearning is oral phonemes go through the door when they shouldn't. It's a learned pattern. Okay. Instrumental assessments are part of, or a crucial part of, not just cleft speech evaluation, but they are also important in terms of determining the cleft team's treatment approach. So, instrumental assessments, number one, give us an objective assessment. So, standard protocols save the cleft team time and effort and gives us the ability to obtain optimal results by minimizing unnecessary procedures. Yun nga, kung hindi naman pala kailangan ng um, surgery to correct VP dysfunction, edi good. Hindi na natin pagdadaanan pa yon. Kung speech therapy lang naman pala yung kailangan. Same then, kung hindi naman pala to resolvable by speech therapy, then they should already go through with the surgery or be recommended for surgery. Instrumental tests also gives us information on speech mechanisms that a simple orofacial examination cannot give. So as we discussed, VP function cannot be adequately observed through intraoral views. This also allows the cleft team to learn together and refine their technique to develop best practices for cleft care. There are differences in opinion as to the best method of assessment in all cases. What we should consider is to be most important is to the examiner should consider what is most important to visualize so that we in terms of selecting the best test and then also weigh the relative benefits and risks of each procedure before determining which type of assessment to use. Although most commonly used methods are direct visualization of the VP mechanisms or nasopharyngoscopy and video fluoroscopy. Okay. All right. This is the video fluoroscopy, I believe. Okay. So a video fluoroscopy is a type of assessment and imaging technique that we do to obtain real-time moving images of internal structures. So you have a fluoroscope, which consists of an X-ray source and a fluorescent screen. In a video fluoroscopic speech study, we use this to evaluate VP function during speech. And it also allows us some information and data in terms of evaluating swallowing disorders. This is most commonly used for evaluation of swallowing dysfunction. Correct. That's a bit leaky. Okay. But it's not used as extensively with advent of nasopharyngoscopy, but still occasionally used by many centers. So we'll see again later why mas nasopharyngoscopy na yung ginagawa sa mga cleft focus centers or cleft cases. I will let you go through that. Okay. But the nasoendoscopy is naman flexible fiber optic and is minimally invasive procedure. It allows for the visual observation and analysis of the VP mechanism or lines during speech, phonation, or swallowing. And mas ginagamit na siya for clinical evaluation of VP function. Yan. Most clinicians feel that nasopharyngoscopy is superior because of excellent clarity of the view, it's in living color, ease of navigation or maneuverability of the scope to see the entire port. And most cleft and craniofacial centers in the US use nasopharyngoscopy or even primarily or even exclusively over video fluoroscopy for these reasons. Mas maganda yung imaging and visual evaluation of the VP function na binibigay ng nasopharyngoscopy. Okay. It's a valuable tool, yes, for evaluation of VP function. It allows the examiner to determine if there is VP closure during speech or an abnormal opening. It also allows the examiner to view the nasal surface of the velum and detect abnormalities, assess posterior pharyngeal wall for enlarged adenoids, Passaban ridge, or even a pulsating carotid artery. If the tonsils are enlarged, they can often be seen in the airway through the scope. So yun din, makikita rin yung impact of the tonsils in speech or in VP closure. And it is useful in determining the cause and evaluation of resonance disorder, but it is also a method used during treatment. So when there is VPI, the information obtained through nasopharyngoscopy is important for treatment planning. The observations provide a clear direction for surgical procedure that is most likely to be successful for the patient if they do need a surgical intervention. If surgery is not an option, nasopharyngoscopy can help the prosthodontist design and modify an effective speech prosthetic device for the patient. So, usually yun yung parang may ganong surgery na ginagawa if it's insufficiency. May appliance or may flap na ina-apply din. Aside from that, yun nga, it's also a valuable tool for evaluation and diagnostic evaluation and treatment. For evaluation also, they can see if there's residual nasality or evidence of the upper airway obstruction. Nasopharyngoscopy can help the surgeon determine the cause and then if there's a need for surgical revision procedures. Ayan. Okay. Primarily used for diagnostic purposes, but can also be used to provide feedback to patient as part of the evaluation appointment. So summary of advantages, yan. For videoroscopy, you can see tongue movement, entire posterior pharyngeal wall of velar contact. Then, nasopharyngoscopy, mas marami talagang makikita. All structures of the VP mechanism, location, size, shape, and cause of the opening, even if it's very small. Best resolution is in natural color, so you can also observe structure itself. See morphology of the nasal surface, see the entire adenoid, view vocal folds, effectiveness of BPI surgery, and pharyngeal flap. Done without radiation or injection of barium can allow the patient to hold the child while in procedure and can give parents results and recommendation immediately after the procedure. Can also be used for speech biofeedback. Okay, so speaking of speech biofeedback, another instrumental assessment that can help with that is nasometry, with the use of a nasometer. It's a computer-based instrument used to measure the acoustic correlates of resonance, audible nasal emission, and VP function. So dito yung pwedeng ma-compute yung nasal score. And it's easy, non-invasive, for obtaining objective data by analyzing the acoustic energy from both the oral and nasal cavity. So it's a valuable tool in both evaluation also and treatment of functional resonance disorders. Ayan. So for nasometry, it provides us data in terms of relative amount of nasal resonance in speech for a passage. So what it does is it captures data regarding acoustic energy in both the nasal, so N cavity, and oral O cavity during speech in real time. This software calculates the average ratio of nasal over total, nasal plus oral acoustic energy of the passage. The ratio is converted to a percentage value called the nasal score. So that's the formula for the nasal score. And then in terms of interpretation, and an individual score is then compared to the normative data. So and can be made regarding the normalcy of resonance. So high scores, kasi high nasonance yung nakuha, suggests hypernasality. Low scores naman, low nasonance, will suggest hyponasal. So yeah, we can refer to available normative data to identify ano yung resonance nila. And I believe, ayan, okay. So, last na ito. Ang pala. Kamusta naman sila meron pa sila exam. Tapos hindi pa kayo tapos. Sino nakakatuwa dun eh? Hindi pa kayo tapos. Siya, may mga tanong siya. Ako, konti-konti lang. Okay. So, for the isometry, yun nga, sabi kasi, di ba, ano din daw siya, it's effective in terms of for treatment. So the isometry is used to measure change in resonance following surgical procedures. So after mong, let's say, palagay ng pharyngeal flap, yan, you'll still do the isometry to see nga kung kumusta nag-decrease ba yung nasal score, such that it is, typical, nag-decrease, nag-increase pa siya, ayan. And then it also helps us kasi in terms of providing real-time visual feedback regarding nasality. So it's a form of biofeedback. So di ba yung biofeedback is something that can help us yung ating cognitive processes, engages our cognitive mental processes to identify or adjust our speaking. Yeah. It's useful in eliminating nasal emission or hypernasality. Can also be useful in helping the patient learn to use VP mechanism after VPI. So it can be used to modify resonance in selected cases of VPI caused by the neuromotor condition. So in conjunction with your other ABTK techniques, let's say you want to reduce yung hypernasality, so occlude, yung mga techniques mo to open the mouth so that sound and airflow go out better, and then apply it while nasology is being done, makikita ng patient if effective ba yung ginagawa nilang mga adjustments or modifications. So, that's it. Thank you. Okay, do you have any questions? Wala. Pag may question kayo, si Miggy.